Do you teach patients to self-massage, or is this technique therapist-led?
I'll go first.
You go first.
We're using words that I don't tend to call my work massage. You might.
I do, yeah.
But I think, you know what, it's the same stuff
Yeah.
with you know, a different label on it. I always love to give my patients self-treatment, self-work, but only after we've gone through a session where we do an evaluation. We start engaging their awareness in an area. We stretch. I mean, basically that's what we're doing. Whether we're stretching fascia or skin or whatever, we're stretching people, right? Can I stretch you in a way that makes your voice feel different? And if so, I'm going to end the session with having you put your hands on yourself and me doing hand over hand with you. Can you replicate what you and I just did in the session? And if so, do that at home. And you know, of course they want to know, well, how many times a day should I do this? And we make up numbers. How long should I do it for? We make up numbers, right? But the fact that they're simply putting their hands there and trying to replicate what we're doing and actually hearing and feeling a different voice, I think is so important. I think the fact that I can send them home with a tool for self-efficacy is huge, not just them relying on me.
I think that's also really important in terms of our ethics as practitioners, because it's more important what they do off the couch than what we could ever do on the couch, because we will only see them for half an hour or an hour or maybe sometimes 2 hours of their whole week. And so, you know, they are going to be with themselves more than we're going to be with them.
Yeah.
And so I think that whatever work has been done on the couch, you know, specialist-led, then they have to take that away with the idea of what needs to be done and what needs to happen next.
Right.
I do teach a nifty little stretch to everyone, regardless of what they've come in for, and unless they have any cervical neck pain or dysfunction. Do you want me to show that or not?
Sure.
Yeah. So I get them to press firmly into the soft tissue of their chest, press their back teeth together lightly, and look up. Hold it for 3-10 seconds, whatever, and then reset. I feel like that's a really nice way of just stretching the front of the neck. And there's going to be so much paralaryngeally that's going to be affected by that stretch.
Yeah.
So I like to teach that to all of my professional voice users who come in. Yeah.
And it's so similar to one that I'll teach where it's basically the same thing. You're taking hold of the skin over the sternum, you're lightly dragging down, and you're seeking up in the air, and I may add a little bit of extemporaneous type of seeking and searching and say, oh, when I go over there, there's that feeling, and because that's what I want to connect them. That's my approach, is all about connecting with that familiarity.
Yeah.
Not that it's not of value to do a stretch for the sake. It's, you know what, we have so many different stories that we use to support this work, and it all works.
Yeah.
Right? As long as you tell the story right.
Right.
Yeah.
What are some common patient presentations?
Well, for the bulk of clients I see for maintenance, who will come to me if they're just starting to feel a little bit fatigued, you know, they're doing a busy show schedule, they're teaching or leading masterclasses during the day and then doing 8 shows a week on top of that. What I often see is a high resting laryngeal position. What I will often see is tension in the muscles of the cervical spine. But do I think, or do I know that is related to the fatigue? No. I do have a sneaky suspicion that there are things starting to creep into our habitual nature as human beings to do with how we hold our mobile phones. And what may or may not be changing as a result of that. I have no evidence to support that, but I just have a little hunch there that something may or may not be going on. I think that as well, when laryngeal height is adjusted or changed, or they experience change over the course of a session, they will feel like their voice is freer.
And in terms of presentations, for me, I have probably a much broader caseload because I'm a physical therapist, which I get head to toe type of issues from foot pain to head pain, but certainly within the context of the work we're talking about here, I get many fewer vocal performers than you do, but I do get some from a performance standpoint. They'll come to me at a point where, while they're touring, the vocal fatigue just gets too much, and we do our manual therapeutic interventions, and we work on repeating the self work so they can help with vocal strain, vocal fatigue, basic tongue tension. But then the dysfunctional patient, they could be head neck cancer post-radiation, it could be muscle tension dysphonia, occasionally a spasmodic dysphonia patient. From day one, when I started doing this kind of manual therapy intervention, myofascial release intervention, I saw the commonality between my cervical pain patient who might be getting classic disc type symptoms down in their arm. When you start moving in the anterior cervical region, retrolaryngeal, to in essence replicate a little bit of that nerve pain, where you start replicating a familiar dysphagia issue, swallowing a pill, different textures, chicken or tofu or whatever, right? Where it was almost like there was this common origin of the problem. And I used to, from that fascial nerve, I call it a fascial restriction. The same fascial restriction was seemingly involved with the cervical radiculopathy as was creating that swallowing issue. And the phrasing has changed, but I've not ignored that pattern that sometimes there does seem to be a duality in terms of the two problems of one, maybe one common origin, without trying to name a pathology or name a tissue.
Yes.
That's the fun stuff for me, is kind of bridging the gap, or bridging that world between the PT world and the SLP world. That's how I ended up teaching this class to speech pathologists, is because some of the myofascial release work traditionally is very helpful for that, for getting underneath the laryngeal region, underneath the SCM, etc., and exploring that world where in one space I can replicate globus, dysphonia, and dysphagia, which is bizarre, right? With one technique, you can kind of sum up all those issues at times. So lots of different common case presentations, I'd say.